So my name is Indiana Best. I'm Métis from Alberta. My ancestors are from Whitehorse Plains, Manitoba, so I'm prairie-centric too. I'm studying the Master of Public Health program right now, and this is definitely an interest of mine, so thank you very much for inviting me here. I would like to take a moment to acknowledge the land that we're fortunate to gather on today. So on Treaty 6 territory and the homeland of the Métis, we pay our respect for the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. So thank you, Peter and Debbie. So first we have our first panelist, which is Mary Ellen Gibson. Maybe I'll just introduce each panelist and then they can come up, and then they don't have to sit here, but they can come up and give their little talk. So Mary Ellen has completed her Master of Public Health as well at the U of S, and she's now working with student wellness as the Special Projects Coordinator. She works with harm reduction initiatives for substances such as alcohol and cannabis. Ms. Gibson also works on sexual assault prevention and student mental health programming. Beyond this, she is currently a research assistant on multiple projects focusing on drug use and harm reduction. So welcome, Mary Ellen.
Okay, thanks so much, Indiana. Good morning, everyone who's here, and to everyone on the live stream. I'm going to talk a little bit today about research that I've been working on for the last year and a half with student wellness here at the U of S. And that was primarily looking at cannabis and how we should be doing education around cannabis, but a lot of this is really applicable to alcohol. So kind of substance use in general is what I'll talk about today. Little bit of an outline, I'll just tell you what my project was and the best practices that I came up with, and some key takeaways that I think are really helpful for anyone who's doing a substance use-based education program. So in the fall of 2017, I was hired by Student Wellness to look at what the best practices are around educating youth around cannabis. And so I undertook this work in 2 phases where I did research on what the best practices are when it comes to educating on substances, which generally in the literature was actually talking more about alcohol than really anything else. There wasn't a whole lot about cannabis at that point in time. And then afterwards, based on that, I developed resources for the University of Saskatchewan. But for today, I really want to focus on those best practices that we came up with. So again, this is just highlighting kind of what that research looked like. So there was very little on cannabis specifically. A lot of it was a focus on alcohol or other illicit substances. And we frequently refer to alcohol best practices and use that to inform other substance education. And the reality of the situation is when we're talking about any sort of substance, we can have these practices transcend the bounds of the substance itself. Just like Debbie had said earlier, is when we're talking about alcohol, it can't necessarily stand on its own, just like if we're talking about cannabis or cocaine or heroin, everything can be talked about in the same harm reduction lens. And I think that's really important. So the best practices. So these are the top 5 best practices that I came up with for any post-secondary that's educating their students on substance use. And I'll jump into them a little bit more specifically here. So peer-based education, maybe it feels like a little bit of a no-brainer, but we do find that peer-based education is really the best way to go. In the literature, as well as talking to experts on campus, the first thing that ever came up was peer-based approaches. And important in that peer-based approach is that we are talking about more than just alcohol. We aren't narrowing in just on alcohol and kind of singling it out as a youth issue, but we're also talking about a lot of the other concerns that are really connected to alcohol, such as mental health, other substances, and kind of the norms or assumptions of what it means to be a university or college student. Harm reduction focus. Harm reduction is definitely a really big part of almost everything that we do, and it's becoming more and more so, I think, a banner of what we want to do more of. So talking about providing information so that people can lower the harms associated with whatever substance that they're using. So for an example, I just threw up standard drink sizes. I think it can be really enlightening to see what a standard drink size actually is compared to what you actually get if you're going out. When it comes to free pouring and pitchers and all this sorts of thing, we have a very distorted perception of what a drink of alcohol is. So having an understanding of what a standard drink size is, we can be more critical when we go out or when we're having drinks ourselves as to what is considered a standard, and then apply that to the lower risk guidelines. The next is social norm messaging. So this is where we dive a little bit into the data, and it can be a lot of fun. So this is just from the reference group for 2016 that I pulled out. But when we're looking at students in Canada, the perceived daily use of alcohol, so students were asked, how often in the last 30 days do you perceive that your peers are drinking? And they assumed that about 12.5% of their peers are using daily. When we ask them how many are actually using daily, it's 1%. This is huge. We have much greater assumption that people are using and using very frequently than what the actuality is. And another piece just to add to that is the perceived rate of never using. They assume about 3.5% of students have never used alcohol. So quite low. In actuality, it's close to that 16%. So again, we're seeing a really big gap between what we're assuming our peers are doing and what that actuality is. And that assumption can create this ambient peer pressure and reinforcing of a lot of those stereotypes that we assume for our age group. And education based on low risk guidelines. So when it came to cannabis, we have lower risk guidelines. When it comes to alcohol, we have even better low risk guidelines, which are really exciting and should be used as really a foundation that we build all of our education off of. This is really a conglomeration of all the best data that we have, the best information that we should be talking to students about. Again, just having that perception of what can be considered a low risk amount and what does that look like in day-to-day life. And finally, I wanted to talk a little bit about having multiple points of support. So when we think about substance use, we usually assume that people are disclosing to their doctors or a nurse perhaps, usually in the healthcare system. But on a college campus, we understand that we are a smaller ecosystem, that people are interacting with other authority figures or other points of contact that can be a bridge to help, that need to be educated in these areas. So talking about academic advisors, residence assistants, other people who are part of this ecosystem, making sure that they have a good grasp of what harm reduction means and what resources are available within our culture, within our community, so that any door is the right door is always a term that we like to throw out there, but really making sure that they at least have an idea of who to refer students to if they're talking about having any sort of problematic use or wanting to get some sort of help, whatever that may look like. So that's a really important point just to think about on campuses, and talking to multiple points and anywhere that students may be going for some sort of help or guidance, that they are able to be connected to the right sources. So I threw up the Be Well logo here as part of our wellness strategy, and I think it's a really important part of that strategy is making sure that wellness isn't just targeting students and staff are over here, but bringing everyone together and understanding that we all have a role to play when it comes to wellness, and we all have the right to our own wellness and finding a way to navigate that system. So really key takeaways just from the work that I've been doing around substance use here at the U of S, really abstinence-only education we've seen is just ineffective and really alienates youth, and a lot of that also can be tied to having non-peer-based approaches and having people who are seen as much higher authority figures or much older can sometimes be assumed to be out of touch, and that really can alienate youth as well. Harm reduction and social norm messaging needs to be our focus. I think that's the best way that we're going to be able to encapsulate the most amount of people, and we're going to be able to make the most amount of change, or at least have more conversations than we've actually been having in the past. Gaining feedback from students and the experts that are at hand. We're really lucky that we do have peer-based education programming here, and our peers are really, really excited to see what other work we're doing and evaluate it. And we also have a wealth of experts on our campus that we can ask to look over what we're doing and always be open to that change and modifying whatever we're working on. And we really focus on having a variety of dispersal methods, again, to multiple areas on campus, as well as having multiple resources digitally or physically available for students. And I think we've already found a little bit of a theme today about learning from others and the importance of symposiums like this, where we can talk about what we're doing, what's working, and what we can be doing together moving forward. So I think learning from each other is a really important part of that. So just as a quick close, I'd like to thank all the people who have been making my project actually happen. So the Saskatchewan Ministry of Health is the funder for this project. Of course, student wellness is a big part of this. Experts who I interviewed, and we had some School of Public Health students work on this project as well. So thank you so much, and I'll turn it back to Indiana.
Thank you, Mary Ellen. That was great. So just a quick note, if you do have questions, please save them till the end. We'll do kind of a question and answer period after all of the presenters have given their brief presentation. And for those who are online, you can just type your questions into the comment field, and then we'll have Graham read them out. So our next presenter is Dr. Colleen Dell. So Dr. Dell is she holds the Centennial Enhancement Chair in One Health and Wellness at the University of Saskatchewan, and she was appointed to this position in 2016. So prior to this, she held a research chair in substance abuse at the U of S, and that was funded by the government of Saskatchewan from 2007 to 2016. Her work focuses on addictions, mental health, community outreach, and training. Dr. Dell is also a professor in the Department of Sociology and the School of Public Health, and she has a lovely guest, Subi, who is her puppy here today. And so please help me welcome Dr. Dell.
All right. Thank you, Indiana. You gonna say? So I want to start by acknowledging the land and everyone for joining us virtually as well here. Even though I'm presenting today, there's lots of people behind this presentation, from the students that we've had working with us as volunteers, as well as employees, the Ministry of Health in Saskatchewan, faculty and administration here at the U of S. So I'm going to share a story about a student-run, theory-driven, evidence-based, campus-supported student binge drinking initiative. And really, it's going to mirror a lot of the all of the best practices that Mary Ellen just spoke about. And we did not plan that. But I know just from listening to that it absolutely mirrors all of that, because we were evidence-based and theory-driven, right? So I'm just going to start with how the story ends, why I leave that to the end. And basically, the conversation continues today on campus from when we started in 2010. And the reason for that is, again, it's theory-based, it is evidence-informed, and it really responded to the culture on the U of S campus. And that was really important. You're going to hear about that more. So when the story started, again, that was in 2010. We had students from a class I taught. It was a joint public health and addictions class, 347, called Studies in Addictions. And they had to choose a campus project somewhere in that field that was a concern. And almost everybody came up with binge drinking as a concern, and they developed mock prevention campaigns. So for students from that class over the summer, they developed a proposal to have this actually occur on campus. And then the following year in 2011, the next class kind of took that a little bit further. So out of all that work, and in the fall of 2011, we had the U of S Student Binge Drinking Prevention Committee. It was developed. And you can see at the same time we developed, or you can't see that, but at the same time we developed a logic model. And that's what's behind here, which is both the aim, or the objective, was to create this effective, multi-pronged, student-driven initiative to address normalization of binge drinking. And then you can see our goals here, right, around sustainability, being proactive, creating this long-term social and behavioral change, and promoting moderation, and as Mary Ellen spoke about, was harm reduction. So I'm just going to spend a second here, or a minute, just to give you that theoretical base and the evidence-based approach behind this, because this is what the students worked so hard on in the class and then in that proposal, and to come up with this student binge drinking prevention initiative alongside Peter Butt, who's going to speak next, and myself. But it's really the students that went into the literature. So on a theoretical base, there were two areas. One was a community coalition action theory, and basically what this was talking, or what this is talking about a formal alliance, and that there needs to be a formal alliance between all the voices. So administration, students, faculty, and so forth. So that was key. So the students had this idea of what they wanted to do, and they went to administration right away and said, hey, this is what's happening on campus. So you had that buy-in from the top, and there was a lot of work involved with that, but that was absolutely key. So also on the theoretical basis, when we operationalized these goals, there was three theories behind all of this. One is called environmental management. And this is where we're looking at the impact, or people's behavior impact by many factors. They include themselves, group processes, community factors, and also even looking at public policy. So what are our policies on campus around alcohol? All of that has to be accounted for if you want to have this long-term sustainable change, right, in attitude and then behavior. So second, under these goals, under these 4 goals here, was, which one? Theory of planned behavior. Okay, so this was talked about a lot and was underlying the foundation of all the activities we then followed through with. And this is the whole idea that if you, the best predictor of behavior is the intention to commit or to perform that behavior, right? So knowing what people's intentions are is really important to then see behavior change in the future. And then third, and this was in everything, we always talk about this, is gain-framed messaging. So instead of telling people, this is what's going to happen to you, these are all the horrible things that are going to happen to you if you drink and drive, instead, or whatever the risk behavior is, we're going to focus on the positive aspects of participating in protective behavior. So it really flips the story upside down, right? So that's the theoretical basis to all of our work. And the evidence-based approach, though there was not a lot of research out there, there were 2 initiatives in the States, and they're the peer-to-peer education approaches, which Mary Ellen has spoken about. One was at the University of Minnesota. It's called The Other Hangover, and the other was at the University of Alabama. It was called Less Than You Think. Underlying both of those were the focus on people's attitudes, because we know we can't just jump to behavior change right away. We have to focus on attitude. So the one from the University of Minnesota, taken from there, and the evaluation that came from that one, is we have to have realistic messaging, right? And the other one from the University of Alabama, where we got a lot of our ideas, was around having swag, social media, contests, and so forth. What's your CAP, which is what this eventually became and was called, is really a lot of fun, and that was really, really important from the peer-reviewed literature. So at the same time when this proposal was created, Peter was helping lead the release of Canada's low-risk alcohol drinking guidelines in Canada, and so that really fit well with our prevention initiative here and moving from this abstinence-based messaging to a culture of moderation. So it was a beautiful fit in that way as well. So along our timeline here, the end of 2011, moving into the first months of 2012, we collected, with funding from the Ministry of Health, some students led a project with us around looking at U of S specific data. So now that's finding about what is the culture of our own campus, because every campus can be very different, right? So we're looking at the prevalence and the culture here. So our students went out and they did things. They did street interceptions. They advertised, they assessed advertising that was happening on our own campus. They reviewed different types of campus events that had alcohol at them, and they also reviewed the emergency room data from our hospital, the RUH, Royal University Hospital, which is on our campus. They completed this report called the Marketing the Low-Risk Alcohol Drinking Guidelines, again, specific to our own culture here. And they did some focus groups and lots of classes to say, what do you think of this? What do you think of that? And that's how the campaign came to be. There's a lot of accounting for diversity, gender, and so forth in this as well. That is threaded throughout. So here's our recommendation. That whatever this campaign was going to be, and now is, had to be applicable to the reality of student life, had to be easily comprehensible, oriented within a youth culture of normalized alcohol use, and contextualized within a peer-led positive campaign that's centered around moving towards this culture of concern and reducing harms. And that culture of concern, as you see in the Be Well strategy and that the other Peter spoke about, right? That was really, really important. That's been threaded throughout as well. So that idea of concern. And that's something we don't probably talk enough about. So this is just the low-risk drinking guidelines rollout, and this is just what came from that project. Just to tell you a little bit more, so number one, resonating the characterization of the low-risk drinking guidelines with students. And again, it was focusing on a culture of concern. The students wanted to know that they were cared for, and putting this alcohol prevention campaign within that culture and that messaging was absolutely important to them. Number two was advertising the low-risk drinking guidelines. So recognizing that the consumption of alcohol for the majority of students on campus was normalized, and for some it was excessive, but recognizing that students are drinking and to not belittle that or however we are responding. Disseminating the low-risk drinking guidelines, we need to speak to the student community campus, incredibly important, speaking to your audience, and involving the campus community in their dissemination, as you've heard about, needs to be student-led, as Mary Ellen had suggested there, and then where feasible, you're having faculty, students, and administration support that as well. And number 5 is coordinating with pre-university entrance. We kind of haven't been as successful as that, of course. Drinking for students prior to university, they're underage, and that is a contentious topic. We've had different discussions on campus about that and the necessity of having those discussions. Different schools are at different places, but that's one door we continue to knock on and try to make change there, to have those discussions and recognize what the reality is and people are doing. So 2003 onward, for my last couple of slides here, we now have What's Your CAP? And that logo was developed with a marketing agency supported through the Ministry of Health again. Love the logo, and we used it in absolutely anything and everything that we did, from, what are they called, like drink openers, or like all types of things with What's Your CAP, to squishy balls and things like that. We had all different kinds of campaigns, and Melissa's going to talk about this afternoon in more depth. I'm just going to give you a couple ideas here. We have the Potty Time campaign, and she'll explain that more. It's called Party Smart, Know When to Put a Lid on Drinking, where we had these great toilets there all over campus and had a game around that. We had infographics, putting that information out to individuals, the stats behind drinking on campus, we've had those around. We have therapy dogs on campus who were to show that concern and that support, right, that sense of care. And we've had lots of activities where we have a door hanger, for example, that says, to pause your stress, visit the dogs. Making lots of different linkages like that. You can see on here, it's called Navigating Your Way. We put a how-to guide for other institutions, and I've spent a great amount of time coming up with that. So that's available free of charge with our lessons learned and tips for others. And we also put this one here, Blindsided. That came out in 2015 towards the end, working with Saskatchewan Prevention Institute and author Ann Dowsett Johnson in looking at the role of media advertising specific to women and girls in alcohol. And then we do tons of outreach, and Melissa's going to share all that this afternoon with tunnels, classrooms, presentations, and so forth. And like I just said, I have the same slide here as Peter had before. Lots of different swag, and Melissa will share that. I do want to just, 2 more slides here, add that we also added to the evidence base, and this is really important for us. We've done presentations. Mostly the students have done these. Our students have won awards from Canadian Institutes of Health Research and other places for their poster presentations. They've done lots of media work as well. And 2 publications, one in the Yale Journal, and the other was a local community-based journal on our own campus. And then Danny here, at the bottom, she was a real leader in a lot of this work. All the students were. She did an institutional ethnography for her master's and came up with some wonderful findings in there that we've been able to incorporate as well. And our current story, my last slide here. So this obviously, I don't know if it's obvious, going back through it and thinking back with Peter, oh my gosh, this was a lot of work. Right? But I think all that work was so important because it's created such a solid foundation. And then when Rita took it over from my office with student health, it continued on its way and it hasn't petered out. And I think that speaks to how solid that foundation is, obviously how important and great Rita's office is with the peer support program too. But because it has that theory-based foundation, and it has that evidence-based foundation, we see results, right? And that is what I think has been able to really allow it to continue, even though we have no employees now, much less funding, now that I'm not in that position to provide funding anymore, but it still exists. So we're really excited about that. And then, yeah, just as Mary Ellen talked a little bit about, and Peter had said, we don't want to just focus on cannabis now. We have to make sure that alcohol maintains its position because of all the harms it does cause society. But because of our foundation, we were able to do some really quick wins with What's Your Cap, Melissa, and with Mary Ellen as well, with her expertise coming onto the campus. We took our door hangers that used to be specific for the low-risk drinking guidelines around the therapy dogs, and on the back, we were able to put the lower-risk cannabis guidelines, and we're able to do that right around when legalization came about. We are now spending a little bit more time with other volunteers to make sure we're having alcohol and cannabis spoken about at our therapy dog events, trying to get that going a little bit more again. And we also came up with Can Your Cannabis with What's Your Cap again, and all the foundation that was there that we were able to, and Mary Ellen, so we were able to hand out cans that for safe storage of cannabis, right? So, but if those organizations, if Mary Ellen through Peer Health wasn't there, and if What's Your Cap wasn't there, that wouldn't have occurred, right? So we were able to get a jump on things based on a really strong foundation that we already had. So thank you to everyone who has been a part of this. It's been an amazing journey, and I'm really glad it's still around.
Thank you, Colleen. That was great. So now we have our last panelist, and then we'll open it up for some questions and a discussion. So next up is Dr. Peter Butt. He is an addictions medicine specialist working in Saskatoon with the Saskatchewan Health Authority. His medical practice focuses on substance use disorders and opioid substitution therapy. However, he has extensive knowledge regarding the National Low-Risk Drinking Guidelines, campus binge drinking prevention, and Aboriginal health as well. Dr. Butt is also a member of the Canadian Research Institute Initiative in Substance Misuse, which is a CIHR, I can't speak today, CIHR-funded initiative. So please welcome Dr. Butt.
Thank you very much. It's great to be here today. I, too, would like to acknowledge the land and the Treaty 6 territory on which we're situated. I really derived a lot of pleasure in hearing the previous speakers because it took me back a number of years in the work that's been done with regards to the genesis of What's Your Cap. And very happy to see it now well instilled in terms of the campus wellness philosophy and campaign. So what I'm going to be concentrating on now is going to be a little bit more technical. If you folks can't see the screen, please feel free to shift on over to the other side of the room. But some of the data is going to be a little bit more technical, so I'll just warn you with regards to that up front. The low-risk drinking guidelines are really ensconced in the National Alcohol Strategy that was developed under the auspices of the Canadian Centre on Substance Use and Addiction back in about 2007. Reducing alcohol-related harm in Canada toward a culture of moderation was released in that year with a number of recommendations. Very much not prohibitive, but rather talking about how do we shift towards a culture of moderation with regards to alcohol use. And central to a number of the recommendations within that document was the establishment of consistent national low-risk drinking guidelines. There were a number of different models out there from CAMH, the College of Family Physicians of Canada, and so on across the country. But what we needed was a national consensus so that the social marketing around it could not confuse people by saying, well, it's this over here and it's that over there in the country. Can't you folks get it together? It reminds me a little bit of a patient of mine who was in recovery and thought that he, perhaps because he had done well for a number of years, could start drinking again using lowest drinking guidelines. So he researched it internationally and found that the most liberal were in Ireland and decided that's where he would start. It doesn't help. It just doesn't help. We need consistency. What is the science? And of course, what we need to be able to address by drinking guidelines are a number of key issues. This is where you would first of all advise not to drink at all, to avoid any harms, because it's exceptionally high risk, such as drinking and driving, drinking in pregnancy. There's good evidence with regards to that. We also have to look at the impact of long-term use of alcohol. And of course, this is something, and a number of these things are going to resonate with cannabis as well. What are the long-term risks and harms of cannabis use? We know with tobacco, for instance, that a lot of it doesn't evolve for approximately 20 pack years of use, a pack a day for 20 years. Then you begin to see some of the health-related harms. Not that there might not be those prior to that, but that's where you really begin to accumulate more of the evidence. So there's longevity attached to the study that's required to look at long-term health risks. And with alcohol, it's more specific with regards to, let's say, liver health and cancer. Then there are the short-term risks of injury or harm. And depending upon where you drink, who you drink with, you might not have a drink before you're already experiencing harm by going into a drinking establishment or a drinking environment where the level of violence perhaps might be higher. You wear the wrong color in the wrong place in this city, and you might be in trouble as soon as you enter the door. Pregnancy, I mentioned, and then youth. This is something that's been studiously avoided by a lot of other low-risk drinking guidelines because they don't want to address underage drinking. What we did here in Canada was to say, we can't ignore this. We need to provide the best advice that we can, and I'll comment on that later. Essential to low-risk drinking guidelines is the definition of what's a standard drink. Now, you can look at this slide and see how it's translated in terms of the grams or mils of ethanol to different beverage types, beer, wine, and spirits. As soon as this slide goes, it will probably disappear from your mind. So then the question is, what does this mean to a consumer? What does this mean at the point of pour? How do people translate this in real life? And this is one of the challenges with regards to the knowledge translation of low-risk drinking guidelines. How do you get it to the point of pour so people understand this and can translate it in terms of how they drink socially on a day-by-day or week-by-week basis? But this is crucial, and communicating this information is really important. So the criteria for low-risk drinking is another very, very important concept with regards to, if we talk about low risk, how do we define risk? In Australia, when they first developed the low-risk drinking guidelines there, they looked around and they said, well, as a society, we accept a certain level of morbidity and mortality attached to motor vehicle crashes. So why don't we compare that to consumption from alcohol to say when that threshold is crossed, you're now at an elevated risk. Well, that was great for the industry because we tolerate a lot of morbidity and mortality related to motor vehicle crashes. So because it's essential in terms of transportation and the economy and so on. That doesn't necessarily work well with alcohol. And so what we landed on in Canada, and it's certainly open for debate, the point is that it's defined. And now, nationally and internationally, we can say, well, is the level that we chose the appropriate one? And what we chose was the net risk of premature death equal to that of a lifetime abstainer. So in terms of people drinking alcohol, at what point does their mortality rate rise above that of lifetime abstainers? That was the level that we used. Now, people would say mortality is a pretty grim way of establishing chronic risk. What about morbidity? At that time, morbidity data was a lot harder to tease out. But that's certainly where the conversation is going. And certainly in a Lancet article that was released earlier this year or late last year, it really demonstrated very, very well that risk from alcohol increases with consumption. It's almost linear. This notion of a J-curve has been debunked. It increases with consumption. So you then have to say, what is the level of risk that we can reasonably accept. Below that is fine, more of a harm reduction approach. Above that, we need to look at different levels of intervention, if you will. So really what we landed on here is the point where potential health risks and health benefits exactly cancel out. That's assuming there's any health benefits at all. And you can see this in the slide. You really look at that line where use crosses and escalates higher than that of lifetime abstainers. The problem is that that works better when it comes to chronic use, but in terms of acute use and acute harms, it's a little bit different. It's much more contextual. So if we look at what happens with the acute harms, some of that is mitigated by the situation, drinking establishments for one. Engineering of automobiles would be another. The level of harm is much less now when people drink and drive because of the safety and security of restraints and the cabin within a car or a truck, as opposed to designs that existed 20 or 30 years ago. So this shifts, and it shifts the social impact of the acute harms of drinking as well. So contextualizing makes it a little bit more difficult. The other area that's grossly absent from the data with regards to the acute harms of alcohol is that of sexual trauma in women. Data's not there, grossly underreported, and that's something that would be extremely helpful because that's usually in the context of acute use. And yet, what's the level that people are more likely to come to harm? And this is an example in this picture right here that some people might take exception to sort of gender stereotyping here, but if you look in the background, the question is that man her wingman? Does he literally have her back, or is he a perpetrator? Who knows in that context? And is she able to navigate that as well, given that it may not be a safe environment that she's drinking in? With regards to the data that we're looking at here, it looks at the percent risk of motor vehicle injuries or the percent risk of non-motor vehicle injuries based upon emergency room data relative to level of consumption. Now, this is pretty soft data. How many people are reporting accurately their level of consumption when they're going into an emergency department or elsewhere following a motor vehicle crash? So this is soft. We know that. Nevertheless, it might be a little bit more accurate with regards to non-motor vehicle injuries, but what we see is a takeoff around that 3 to 4 drink mark, and then it starts rising. It still begs the question, what's the level of risk of harm that people are willing to tolerate here on an acute basis? So this is very transparent and open to debate. When we look at risk curves in terms of chronic conditions, it varies a great deal. A lot of the cancers are gastrointestinal cancers, starting with oral cancers, going all the way down to rectal cancers. And this also, although it's not showing on this slide, includes breast cancer, which is something that's not well communicated to the population. You also see harms related here to ischemic heart disease, which is much lower, epilepsy, pancreatitis, low birth weight, and so on. So again, this was the data that we could use in terms of the impact in terms of chronic harms. Roman Company did a great deal of work in terms of coming up with these slides, which I think help to convey much more graphically what we see in terms of perceived benefits. And here, this is the percentage change in long-term relative risk by average standard drink sizes for both men and women below the age of 70. And you could see the relative benefit here of ischemic heart disease, which of course is what the alcohol industry is all over, followed by the media, which promotes this notion of heart health through alcohol. Data isn't really all that good, quite frankly, but it's at very, very low levels, just 1 or 2 drinks, whereas in the same realm, when you're drinking that amount, there's still other risks that people are exposed to, and you see the immediate increase in risk in terms of cancers of the GI tract, liver disease, as well as pancreatitis and dysrhythmias. That's for both men and women. When we look at what what we have for just men alone, you begin to see, yes, some protective effect in terms of ischemic stroke, but in terms of hemorrhagic stroke, it's elevated. So if you have a crystal ball and you know which stroke you're going to have, then maybe it's okay to have more alcohol or less. None of us have that. You might look at family history and know that you're at increased risk. But this really lends itself to debunking, I think, some of the promotion of alcohol use for health purposes. Of course, this also applies to cirrhosis for men. When we apply it to women, here you can see the impact on breast cancer. There's a 13-fold increase of breast cancer even on a drink a day. So if you're a woman with a family history of breast cancer, this is probably important information in terms of mitigating how much you drink. Are you going to drink at all? What's your risk factor? Are you going to drink within the lowest drinking guidelines, or are you going to cut them in half? So individualizing risk is very important when we take this data from a population health basis to a one-on-one conversation with people. This isn't something that's well known, unfortunately. With women, though, you do see some benefit in terms of hemorrhagic stroke like men, but not from clots, or pardon me, not from bleeds. The other, of course, is still the impact on cirrhosis. Very, very high. You see here at the bottom, liver cirrhosis and mortality from women is very high related to alcohol compared to men because of the difference in the metabolism of alcohol, which is why we have two different levels for women versus men. Alcohol is metabolized more slowly by women. It hangs around longer for the same amount of consumption and has a more negative impact. So if we look at relative risk for all-cause mortality, we scanned the literature. There were some good systematic reviews. And what you see here is some clustering in terms of increased risk for women, generally around that 2-3 drinks per day, and with men, more of that 3-4 drinks per day. So this was the basis for the numbers that we end up with in the National Low-Risk Drinking Guidelines. Here they are as when they were released. It's important, and this was part of the knowledge translation that was a bit of a challenge right from the beginning because people thought, well, you're just promoting alcohol. And we're saying, no, that's not what we're doing at all. Let's step back a little bit. And really, it's not intended, these low-risk drinking guidelines are not intended to encourage people who choose to abstain for cultural, spiritual, other reasons to drink, nor are they intended to encourage people to commence drinking to achieve health benefits. There's no evidence to support taking up alcohol for your health. Zero. Nevertheless, it's also important for people to realize that if they're low body weight or not accustomed to alcohol, they need to make their own judgment in terms of how much they apply. For some people, the low-risk drinking guideline limit recommendations would be too high. So it has to be individualized. So by the numbers, there's clearly situations, including pregnancy, where people should not drink at all, should abstain because of the high risk that it poses to themselves, or if they're responsible for caregiving or something else, the people in their care. Similarly, as you know, with regards to previous slides, 0 to 2 standard drinks for women on a drinking day, no more than 10 per week. For men, that 0 to 3 per day, no more than 15 per week, encouraging non-drinking days, so there's intermittent abstinence on some days, so it becomes less habit-forming. This is emerging to be very important in the world of cannabis as well, in terms of the difference between people who smoke every day and those who do not. The impact on the brain and the ability for the brain to recover, even though it's very lipophilic. In Canada as well, we recognize that there's a pattern not so much of daily drinking with meals, wine with meals, as you might see in some European cultures, but more around episodic drinking, clustering more around weekends or special events. So we cut people a certain amount of slack in terms of special occasions. Every Friday is not a special occasion. That's important to convey to people, but going up to 3 for women, going up to 4 for men, but still staying within that 10 and 15 limit per week in terms of standard drinks. So that if they're going to have more on a Friday night or a Saturday night, they're cutting down on other days of the week, and just being more deliberate and reflective with regards to the approach. And there are recommendations in terms of how to stage drinking, so the alcohol intake is slower, it's done intermittently with non-alcoholic beverages, food is consumed, and that sort of thing. Again, a harm reduction approach to decrease the blast to the brain. And I commented on pregnancy already. Alcohol in young people was another one that we really felt we needed to focus in on, and it comes out. This is something that really is challenging to communicate well, but it comes out as delay, delay, delay because of the impact on the developing brain. So the longer a person delays, the less likely they are to come to harm, not only during adolescence and young adult years, but also later in life in terms of the development of an alcohol use disorder. However, and this is where it seems to be contradictory. If a person has chosen to drink, the advice is to keep it within the low-risk drinking guidelines, never more than the 2 for women, 3 for men, and not on a daily basis. Now, the knowledge translation around that is a bit challenging, which is why it was a distinct privilege to be involved with What's Your Cap, to see how this information gets translated and worked through in a peer-led program so that it has meaning and can be taken up by the population we're trying to reach. The challenges with regards to the knowledge translation, as I referred to before, relates to, well, labeling on beverage alcohol. How many standard drinks at the point of pour is there? This is an example of one that was done by an entrepreneur and physician here in the province, Dr. Michael Goldme, with his distillery, Lucky Bastard. And it shows the beverage here, in this case it's liquor, and the number of standard drinks within that, as well as the low-risk drinking guidelines on the bottle at the point of pour to help people with that. I was on the CCSA-led committee looking at standard drink labeling for beverage alcohol, and working with industry was interesting but also extremely challenging. I think they were there more to get intelligence in terms of how we think rather than doing anything. We were at least able to come up with what a label, a standard drink label might look like, a prototype, if you will, but absolutely zero commitment from the industry with regards to implementation. And yet, if you stop and think about it, if we have heavy promotion of low-risk drinking guidelines, people are going to be looking for more low-alcohol content beverages. And if they switch their thinking from promoting alcohol to promoting beverages, many of which could be low alcohol, then they can sell more beverages, more product within the low-risk drinking guidelines than if it's a high level of alcohol. So there are ways where industry could be partners in this and actually sell more low or no alcohol beverages and maintain market share. And now Abendev, in a multinational beer consortium, is looking at this. They want to reduce the impact of their beer products and their harms, if you will, by 20%. And they're doing that by increasing their sales of no alcohol or low alcohol beer to be 20% of their market. So they're seeing a niche, they're seeing an opportunity, and they're doing something that I think is going to reduce harms in the future, yet to be taken up in a very active way here in Canada. The other challenge, again, is that at that point of pour. And What's Your Cap has done great things with mocktails and non-alcohol equity access to concerts and in clubs. And this is part of the social marketing. In terms of pubs, clubs, and other events, are people who don't drink alcohol or are wanting to drink at lower levels encouraged and comfortable to participate. What does that look like? How do you do it in a way that doesn't disrupt the socialization that's going on? It's about having fun. It's not about getting drunk. How do you navigate that, again, at the point of pour? So you have alternative beverages, and that's a simple way to do it. But you also want to ensure that the people that have access to the front of the stage aren't only in the drinking area. You know, the people who don't drink can have access to it as well. And other strategies like that. Non-alcohol stress relief is something that's been promoted, but also with regards to the hospitality industry, and this applies to the hospitality sector on campus. they're selling product. Hopefully that product includes low alcohol or non-alcohol beverages in addition to just promoting alcohol alone. So sometimes what we found is that there's actually resistance in the campus community if they're being very much driven by marketing alcohol rather than thinking about this more broadly in terms of the wellness strategy. And of course, this then needs to be embedded as it has here at the U of S, and it's wonderful that it's embedded in the wellness plan and strategy as well as in student health. One of the things that was referenced here is as you shift further along in terms of intervention, when people are drinking above the lowest drinking guidelines, they're at elevated risk. If they're beginning to have harms at a significant level, they may then meet criteria for an alcohol use disorder, either mild, moderate, or severe. So from the intervention side, certainly early on, we reinforce the lowest drinking guidelines. If people can stay in there, good for them. If they've lost control and they can't stay in there, then we need to look at escalating levels of conversations and interventions. So that's essentially what happens with screening, brief intervention, and referral for more specialized care at a primary care level. And this is a slide from the College of Family Physicians of Canada. It's an open access website. You see the process map. You ask, do you drink? Yes or no. Are you drinking within the lowest drinking guidelines, quantity and frequency, yes or no? Are there reasons to individualize risk here, yes or no? Provide the advice, and if there are harms, start thinking about different levels of intervention. But if you deconstruct what was done with What's Your Cap, it's very much taking that approach of screening, brief intervention, and referral, and applying it to a social marketing campaign. So that's what we did in the Yale Journal, is we basically deconstructed it and compared it to screening, brief intervention, and referral. That wasn't our intent, but it was really interesting how it evolved and distilled out in a way that was more applicable to the campus population.